5, 4, 3, 2, 1. Let's get started. Well, welcome everyone. Today I'm really excited to talk to you about innovative diagnostic and treatment options for non-surgical orthopedic conditions. I'm a PM&R sports medicine physician and look forward to talking to you guys about the evidence of non-surgical orthopedic conditions and some of the advances that have been made over the past several years. So first, I want to thank the Gildenhorn Orthopedic Center at Sibley Hospital. It's an amazing place to get orthopedic service. I actually was born at this hospital, and I'm glad to be giving a talk to the community today. I do have a disclosure to make. I am the Chief Medical Officer of Limber Health, a digital physical therapy app that allows people to do home exercise at home. A little bit about myself. So I was born and raised in Bethesda, Maryland. Previously, I was a personal trainer and collegiate basketball player. My background was in exercise physiology and biomechanics. My medical school was down at Virginia Tech. Residency was at Georgetown, fellowship at Mayo Clinic in Rochester. And then I have a unique ultrasound certification in diagnostic musculoskeletal ultrasound. This certification allows me to look at a tendon or soft tissue area and see if there's an injury without saving most patients an MRI. A little bit about myself and my thoughts and beliefs really come from when I was at Mayo Clinic and I was at a one-stop shop orthopedic center, really focused on taking yoga, Pilates, exercise, physical therapy, surgeons, physiatrists, and physical therapists working together in a harmonious environment. And that is a big part of how I like to practice and understand my lanes in the way I can provide care and really understand all the different approaches that can be done to manage a musculoskeletal injury. Today, we're going to talk about, from a timeline perspective, we're going to talk about the evidence of non-operative care. We're going to talk about tendon scraping, which was developed at Mayo Clinic, where I was, and as well as Tenex, which is a tool used for common orthopedic tendinitis. We also a tool called that we use for releasing the tissue for people who have a condition called chronic exertional compartment syndrome. We're going to talk about carpal tunnel release that can be done in a new minimally invasive way, trigger finger release. I also will talk about frozen shoulder, the evidence behind some of these regenerative medicines and what exists today in the literature, and then diagnostic ultrasound and its use in managing an orthopedic injury. Before I get started with talking about procedures and some of the other advances that have been made, I really think it's always important to stick to the basics. And the British Journal of Sports Medicine this past year came up with a new review on what is the best practice to manage a musculoskeletal injury. And they came up with a whole 11 consistent recommendations from high quality clinical practice guidelines and systematic reviews. So what was known from before they did this was that there was an urgent need to improve quality of care for orthopedic conditions. Additionally, there was a need for, we know that MSK pain in different body areas, there's a common theme that can be managed, and there's common overarching recommendations that could be developed from these guidelines. I think it's really important to educate the community about some of these guidelines because a lot of it is still not being practiced in the United States today. The first one showed that there was a large overuse of imaging. Between 25 to 42% of patients with low back pain had unnecessary imaging, which is strongly discouraged, especially as the first part of their care pathway. The same went with looking at rotator cuff tendonitis. And if you look at people that have arthritis or have tendonitis in their 50s and 60s, there will be some wear and tear changes that is on that area. But that does not mean that that image finding necessarily correlates to a finding in that is actually causing them their pain. Second recommendation was that there was a large overuse of surgery. Knee arthroscopy for non-obstructed meniscal tears, the clean out of the meniscus for arthritis, is not recommended, as well as some of the rotator cuff repairs in patients that, and there were a few studies that compared that to surgery, physical therapy to surgery, and showed equal outcomes. The third recommendation is that there's an overuse of opioids in the United States, and that opioids should be discouraged, and that there's poor outcomes when patients are started on an opioid for an orthopedic condition. And the last one, which I think is near and dear to my heart, which showed that that there's a lack of education and advice, which is really important for managing orthopedic conditions, especially at the initial set of care when they see a primary care doctor or someone else within the community. And there were some recommendations that were made. The biggest ones that I want to highlight here is that radiological imaging should be discouraged unless there's serious pathology. Most people should go to therapy as the first line of care for most orthopedic injuries. Secondly, when they do go to physical therapy, it's really important that they have active therapy, meaning that they get strengthening of their muscles to support the structures that are injured, and not just manual therapy and soft tissue techniques. And the third one was that that if patients don't have a red flag, meaning that there's not something very wrong, they should really focus on non-surgical care before going to surgery. After going over that, I'd like to introduce you guys to some of the procedures and other non-surgical and minimally invasive procedures that I do, and what is the evidence behind them. And I'm sure I'll have a lot of questions to answer after this. The first one is a procedure that we do under ultrasound guidance, where for patients who have patella tendonitis, so it's tendonitis on their kneecap, or Achilles tendonitis, meaning the tendon, the Hercules tendon behind their heel, can get inflamed, and there can be some inflammation that happens between the tendon and the fat pad in that area. So what we do under ultrasound is we identify the injured area, and then we use a special tool to separate the tendon and the fat pad. And this was developed at Mayo Clinic and is a very unique and procedure that can be done for some patients. And what it is, so this right here, you see the patellar tendon, and this is the tendon that we can see under ultrasound. And what we can see here is all this color here is inflammation that is between the tendon and the fat pad. And that is causing a lot of pain for the patient. So what we do is we use a special tool under ultrasound to get rid of the inflammation between the tendon and the fat pad, allowing patients to go back to playing sports and exercising a lot quicker. Since we're not going into the tendon, as you see in this picture where you see this needle moving, we're able to help patients get back to exercise within a matter of weeks. In addition to tendon scraping, which patients can go back to exercise in a few weeks, I also do some procedures that go into the tendon. And those procedures that go into the tendon, I really have a 6-week rehab protocol that gets them back to activities that they love and enjoy. And if you come to Point Performance or Sibley Hospital, we really believe in a conservative approach, both before their procedure and then after their procedure also. And the second tool that I use for common orthopedic conditions is for tennis elbow, golfer's elbow. So a lot of golfers out there. But patellar tendonitis, plantar fasciitis. So that's something that they have a thickened plantar fascia on the bottom of their sole. So they'll have heel pain, Achilles tendonitis, and then also for calcific tendonitis, which occurs in the rotator cuff. And for these procedures, there's a new minimally invasive procedure that I offer. And I'll go into detail about what that is, but essentially what this procedure is, and this was the basic science that was done at Mayo Clinic, showed that where the tendon is injured, there is an area of tendon that can't be healed correctly. And so what we'll do under ultrasounds, we'll debride the bad area of the tendon while preserving the rest of the normal tendon. And we do this just using ultrasound guidance. And this was a study that showed on animal models that showed when you take out the portion that's degenerated and allow the tendon to heal back up on its tracks, it can occur. And this was one of the earliest studies of the applications of Tenex. And to date, there's been many articles over the past several years published in orthopedic journals showing Tenex to be very effective and long-lasting, which I'll show you in a second. And one of the studies, or one of the things I like to highlight, is that around 85% of people, depending on the body, will have some very good outcome to manage their orthopedic injury. And this will range from 89 to 95%. I would say the highest success rate has been in the elbow, the plantar fascia, so on the bottom of the foot, and the knee. And this is an example of someone who has inflammation in their elbow. So right here where tennis elbow occurs, and this usually happens as an overuse injury that can be very debilitating for not just tennis players, but for anyone who does a lot of manual work. And this is an image of what the tool is. So under ultrasound guidance, I make a little incision, and then I see where the injured area of the tendon is. And then I take this tool and I'm able to remove the damaged area of the tendon while preserving the rest of the tendon, and allows me to effectively keep most of the tendon intact while taking out the bad portion that's causing a lot of pain for the patient. And so a lot of people ask, what is the evidence for some of these newer treatments that we were doing at Mayo Clinic? Well, this is a really good study that for Tenex, for tennis elbow, and it showed 3-year follow-up of patients' pain and function improvement, and also image improvement over those course of 3 years. And this was a study that I just saw that came out recently that showed 7-year follow-up. So these patients who had very bad tennis elbow that didn't improve with physical therapy, this study showed 90 months improvement that was published recently in the American Journal of Sports Medicine. And this is kind of what it looks like. So this black area is where there's a tendon tear, and then you can see the tendon filling in, there's more white area, and then there's more white area, and then the tendon is more filled in at this point. And this is patients' pain going down and their function improving. And you can see that their pain and function is improving tremendously from this procedure over the next 3 years. This was a study down at Emory University where they've done a lot of research comparing platelet-rich plasma, which I'll be talking about in a little bit, versus Tenex. And this treatment showed that PRP versus Tenex for tennis elbow and golfer's elbow showed equivalent outcomes. And this was published in the Journal of Shoulder and Elbow Surgery. A lot of people say, well, how does this compare to surgery? Is this going to affect me having a good surgery if I need to go on to a good surgery? Well, they actually compared in this study, they took people for tennis elbow and compared them to people who had surgery, and people who had quicker recovery with the Tenex and similar outcomes than people who went on to get surgery. The next procedure that I do is really a nice procedure for patients who have calcium deposits that end up in their rotator cuff and other parts of their body. And you can see in this picture here, this white area is a large calcification that is in the rotator cuff tendons. And this is what it looks like on X-ray. And so we use special needles and other approaches to remove these calcifications under ultrasound guidance. And you can see after the treatment, that calcification is no longer there. So this is what it looks like. So we have a needle that goes into the calcification, and we're actually able to remove the calcification under ultrasound guidance, preserving the rotator cuff tendons, which are really important for shoulder stability. The next procedure is one of my favorite procedures that I do, and it's for patients who have numbness, tingling, and weakness in their fingers, usually their first 3 fingers, and they usually have pain around their wrist, and it's due to a nerve being pinched right at the wrist. And traditionally, a patient should go through physical therapy, bracing. Sometimes people will get an injection, and then surgery might be indicated. And there used to be 2 approaches to surgery. There used to be an open surgery where they would make an incision in your hand, and that incision would take a long time to recover. And there could be complications that happen from that. The second surgery is called endoscopic, which they use another tool in the OR for cutting this ligament under ultrasound guidance. Cutting this ligament. The third, this newer procedure, if you go to Mayo Clinic, this is the procedure that most patients have done today, is an ultrasound guided carpal tunnel release. So instead of having an incision in your hand, you have a small, very teeny incision, and then we take this instrument and can cut the ligament under ultrasound guidance. And this is what it kind of looks like. So we identify all the areas where an injury could occur, and we see where the nerve is, and we see where the artery is, and then we see the ligament that is pinching the nerve. And then we can actually cut that nerve under ultrasound guidance. And so here's the balloons opening up. And then we have a special blade, only when the balloons are open, that can cut that ligament under ultrasound guidance. And a lot of people ask, well, what's the evidence for this new ultrasound guided surgery that has been done recently and has been done at many institutions? Well, this is a study that was done at Jefferson Hospital in Philadelphia and showed 1-year outcomes of people with the ultrasound guided carpal tunnel release, and showed quickly improvement in hand function and pain that persisted over 1 year. And this is one of the first studies that showed that it was safe, effective, and less invasive than alternative surgery. A second study showed long-term clinical results of carpal tunnel release under ultrasound guidance. And this study showed very good outcomes over a course of a year, and showed faster recovery than traditional surgery. And in addition to this procedure being minimally invasive, it can be done in an ambulatory surgery center or the office. And there's been a lot of evidence showing that it can save a lot of cost in the healthcare system if done correctly. The next procedure that I'm going to talk about is called the trigger finger release. So most people will have some type of locking or pain at their hand, and it will cause some locking in their fingers. And this is due to one of the pulleys. So there's usually 6 pulleys in your hand. One of those pulleys get thickened and push on the tendon, and that pushing on the tendon causes the locking of their fingers. So what we do is actually can release this pulley under ultrasound guidance, which is a lot quicker than traditional surgery. So what we do in this picture is you see this needle being introduced into the area, and we can release that pulley under ultrasound guidance. And this is kind of what it looks like under ultrasound. So these are the tendons. This right here is the pulley, and this white structure is the needle. And we can release that pulley while preserving the tendons under ultrasound guidance. And this is it just releasing. And we can see it release afterwards because there's less locking of their finger. The next procedure that I'm going to introduce you guys to is, so for some patients that have cancer, diabetes, or thyroid disease, or an injury either before surgery or after surgery, is called frozen shoulder. And this is someone who can't move their arm and they're very restricted in motion. And so this is a procedure where we put fluid in the shoulder to allow the shoulder to have more motion. And it's been well studied, and it's a really good non-surgical outcome, non-surgical procedure that can be performed with physical therapy, and there's been good outcomes for this. Here's a patient who I saw in the clinic that had a good outcome.
Let's talk about one treatment option for frozen shoulder. This injection is a solution of saline, lidocaine, and steroid, which goes directly into the shoulder joint under ultrasound guidance, breaking up adhesions and expanding the joint capsule. This patient has been doing physical therapy, but was seeing limited improvement. Immediately following the injection, you can see the difference in her range of motion. The patient received immediate relief after the procedure.
Wow, that's pretty amazing, actually.
This technique is used in conjunction with physical therapy as part of our integrated medical.
And so in addition to that procedure, there are other procedures that we do now that are minimally invasive that can really provide great outcomes for patients. So for some patients, this is a very rare condition. They'll have something called chronic exertional compartment syndrome, which is a cause of the muscles putting too much pressure within the legs. And it can cause foot drops in patients, especially runners that have difficulty running, and they'll be running for a period of time, and then they'll get some foot drop. It's a very rare condition, but you used to have an incision that would go from here all the way down to the ankle. And now using ultrasound, we can actually cut that area of the fascia, allowing the muscles to breathe more. And most people after this procedure can go back to running within 10 days. And this is kind of what it looks like. Under ultrasound guidance, we have a special tool that one part of the blade goes above the fascia and the other goes below. So that's the tissue that surrounds the muscles that prevents it from opening up. And we actually are able to release that tissue under ultrasound guidance. The next part of my talk is going to be focused on hip and knee arthritis. 1 in 2 Americans in the United States will have a musculoskeletal condition. Arthritis has been increasing. Sibley Hospital is a center of excellence for treating some of these patients for hip and knee arthritis. But one of the things that I've seen is that hip replacements do really well, but the difference between physical therapy not improving your pain and a hip replacement or a knee replacement, it can be very challenging. And so there's been newer treatment options to help patients improve their pain, delay their need for a hip or knee replacement that we'll talk about today. Unlike hip replacements, which have really good outcomes, 30% of Americans are unhappy with a knee replacement in the US. And it can be very challenging to get a good outcome. In fact, this article published in the Washington Post showed that 20% of people are actually dissatisfied with a knee replacement. So a lot of people ask, what can be done? Well, Well, now using digital health and machine learning, people from Harvard and Stanford are trying to really understand who's a good candidate for getting a knee replacement. And that they're really trying to identify the sweet spot of what's the optimal age and how debilitated you have to be before a knee replacement would be a good option for you. And so between physical therapy and a knee replacement or a hip replacement, there are newer options that I will talk about today. So one of the things that's really done poorly in the community today is there's a lot of people doing regenerative medicine, which we'll talk about, and they're promising false narratives. And today I just want to go over the evidence and what we know about the evidence today. When I was at Mayo Clinic, we studied this very meticulously, and we saw that people who, that it doesn't regrow cartilage for a lot of people, but it can really improve pain and function for a considerable amount of people. And we'll talk about what is the evidence, what type of treatments are out there for patients who are suffering from arthritis. So there's two different types of treatments. One is called platelet-rich plasma, and the other one's called stem cells. And we'll talk about platelet-rich plasma first. So platelet-rich plasma is where we take your blood and we spin down that blood to get platelets. And those platelets have growth factors. They're actually very important to healing. And we inject those platelets into your body. So we take your blood in the office, we centrifuge it, and we get those platelets, and those platelets help promote healing a lot longer and faster, and a lot longer and are healthier than a traditional steroid injection. And so PRP today, we'll go over the evidence of what it's used for, but it's used for tendinitis, it's used for arthritis, it has been used for muscle injuries and ligament injuries. And the science behind PRP for arthritis is, once again, those markers of inflammation cause cartilage breakdown. So the earliest start of arthritis is that the cartilage is broken down because there is some inflammation that's happening in the joint. And so PRP adds these growth factors to stimulate the joints to continue to be healthy and also decrease the inflammation for a longer period of time. I can really speak candidly that it's been well studied at this point, and it's very safe, and especially since it's your own body's platelets. But a lot of people want to know, what is the evidence about PRP for arthritis? Well, a lot of it has been done on the knee. And today I'll talk about some of the studies that have been done on the knee. First, these two studies looked at level 1 randomized control studies. So these are the best studies that we have in medicine. That means that they have two groups. One, for some groups, they're blinded, meaning that they don't know what the intervention is going on. And they compared PRP to Synvisc or hyaluronic acid, which is a gel that is used traditionally today and covered by insurance. And they showed that PRP did better than the gel at 1 year. And both these studies looked at a lot of level 1, so the best evidence studies that we have, and showed that PRP was better than traditional gel injections. And this study that was published actually in Baltimore, Maryland, showed PRP versus gel, and they showed only double-blind control studies. So that means that the patient didn't know what injection they were getting, the doctors didn't know, and they showed that PRP had significant advantages compared to the gel injections that people traditionally knew about. And now there's been so many studies of PRP for arthritis that they're doing cost analysis. And if you have early to moderate arthritis and it lasts greater than a year, this is a good option for you for improving your pain, function, and quality of life for a longer period of time than traditional injections, which can be shorter term. Now I'm going to switch over from arthritis to tendinitis. So the first study that was done at Stanford showed PRP for tennis elbow, and it showed that early on there wasn't a huge change compared to conservative care, but they showed at 24 weeks that PRP had a better outcome than traditional care. And so this is one of the first studies that was done at multiple centers that showed that PRP could be effective for tendinitis. And now there's been a lot more studies on tendinitis. These are two that I think are noteworthy. The first one, which was done in Australia, so a lot of tendinitis or trochanter bursitis that happens on the hip. This was a 2-year study showing that PRP was effective for helping the tendons, which these tendons can be inflamed on the hip, and the PRP helped improve their pain, function, and quality of life at 2-year follow-up. So longer-term outcomes for seeing if PRP was effective. This other study for golfer's elbow, so we talked about tennis elbow, which is on the outside part of the elbow. This is for golfer's elbow, and it showed that PRP was equal to surgery, and this was done at Tulane Hospital. And it showed that PRP was effective compared to surgery for this chronic tendinitis. And now there's been a lot of studies showing PRP for tendinitis. I would say they're not all great, and there's more research that needs to be done, and it works better for some parts of the body than others. It's not all body parts are the same, but for certain body parts, it can be very effective. So the evidence of PRP, is it effective for arthritis? I really think the evidence at this point for arthritis is there's overwhelming evidence really supporting that PRP can be effective for improving pain, function, and quality of life. It does not regrow cartilage, but it can really improve the quality of the knee joint, and it lasts longer, usually at the very least around a year. Is PRP effective for tendinitis? There are longer term studies that are need to be done, but early studies have shown that PRP is effective for tendinitis, and it's showing long-term relief compared to a steroid injection. But more studies are needed. The next thing that I want to talk about is definitely more experimental. This needs more research, but there's been some very promising studies that were done recently. At Mayo, we were doing a lot of studies looking at cultured stem cells, adipose stem cells, and I'd like to talk to you guys a little about what the evidence is for some of these stem cell procedures that you've heard on the news and also in the community. So first of all, how do stem cells work? There are cells that are taken from your bone marrow or from your fat, and they differentiate into appropriate tissue, and they can prevent the degradation of that tissue. That has been shown in animal models, but has not been proven to date in human models. But these stem cells do have a lot of implications. In fact, today, regenerative medicine is considered accredited, especially at Mayo Clinic. So there's more and more studies that are coming out about the capability of using stem cells for treating orthopedic conditions. And there's two locations of where these cells are taken from. One is the bone marrow, and the second one is the fat. And those two areas have a lot of stem cells, and allows for you to do FDA compliant treatments to treat those injuries. And once again, this is still very experimental, but there have been recent studies that have shown great clinical results. This study was done at Rothman Institute in Philadelphia, so a large orthopedic institute, and it showed adipose stem cells. It was a double-blind, randomized control study, and it showed adipose stem cells to decrease pain and improve function for at least a year compared to the control group. And this study showed 3-year follow-up data showing that adipose could be effective for treating knee arthritis. And this study that just came out, I'm very excited to talk about this one, was a study done out of Emory University, and it was a multi-site study, international study, published in Orthopedic Journal, and showed 2-year follow-up data in patients over 60. And it showed that for not only mild arthritis, but for moderate arthritis, that this is a very effective treatment for patients over the age of 60. So this is one of the first studies that I've seen really looking at older patients and seeing if this could be an effective treatment for them. And now there's been more and more research, 2-year follow-up data showing that stem cells could be effective. And in addition, this is another study that was published at University of Southern California in the Department of Orthopedic Surgery, and it showed their recommendation was that there was strong evidence that stem cells are safe and they generally have positive clinical outcomes. And so there's more and more studies coming out, but it's still in the more experimental phase at this point. But I think it will have a role treating arthritis in the future. It's really important with any of these regenerative medicine procedures that if you're going to consider this, that it's not like a steroid injection. You need to go through a 4-week protocol for arthritis. And then also, if it's going to be for tendinitis, it's even a longer protocol, like 6 weeks. So most people, for their knee joint, they'll have more pain than they do before the injection. They'll last about 3 days. Then they will start working on range of motion and strengthening and be back to activities within 3 to 4 weeks. For tendinitis, it's around 6 weeks. The next study that I'm going to talk about is near and dear to my heart. So I told you guys I have an ultrasound certification, so I can save a lot of patients unnecessary MRIs. And I'm going to talk about the diagnostic use of ultrasound for treating non-surgical orthopedic conditions. First of all, for the shoulder, we can see the entire rotator cuff tendons. We can see if that tendon is torn. For a lot of people that are claustrophobic, this can be a really good test to see if there's a tendon tear. And if they didn't improve with physical therapy, this is something that we would consider. We can also use it to look at nerves, look at ligaments. We can evaluate to see if they have carpal tunnel syndrome. We can use it for most orthopedic injuries of the shoulder, elbow, wrist, hip, knee, ankle, and foot conditions. And this is what it looks like. So this is a normal tendon. You see how it's very white. And this is a normal biceps tendon. It's also very white. And you can see pretty clearly, because ultrasound is able to zoom down really close into the body, you can see if there's tearing. So this black area, there's a little bit of tearing. You can see if the tendon is moved out of its normal location. So this tendon is moved out of its normal location. Or you can see if there's a full tendon tear. So this picture is a tendon tear of the rotator cuff. One of the rotator cuff muscles that allows you to move your shoulder was torn in this patient. And a lot of people ask, well, how does ultrasound compare to MRI? Well, it is operator dependent. It really needs to be done in the right hands of a person. But if it's done well, it can be equally effective to an MRI. And some might say even more effective than traditional MRI. In addition to looking at tendon tears and other soft tissue structures, we can see cysts. So this is an MRI of the knee. So this is the front of the knee. This is the back of the knee. And this is a cyst that is in the knee. So we can actually remove this cyst under ultrasound guidance. That cyst will reaccumulate for patients sometimes, but it allows them to have more range of motion, especially if they're not ready for surgery. And there's a lot of other cysts in the body that we can remove under ultrasound guidance. The next thing I'll talk to you about is a review paper that looked at the evidence of using ultrasound-guided injections. So a lot of people still to this date will get blind injections. So the doctor is doing an injection and they're not using some type of guidance to see where that injured area is, which is really important. And we'll talk about the studies that are done across the body. The most important study to date this article looked at all the different joints of the body and showed that ultrasound was more accurate for the most part, for most body parts, and more effective than traditional blind injections that you might see patients get today. And this also was done also in the hip, knee, foot, and ankle. So what we know now is that ultrasound guidance versus landmark guidance can really have an effect. And this study was a large study that was done at Mayo Clinic, and it showed that half the people had ultrasound guidance and the other half had blind injections for the knee of the gel. And it showed, they followed them out for 10 years and showed that the ultrasound guidance had a longer recovery, a longer improvement of their pain and function, and less likely need for knee surgery compared to someone who had blind injection. And this is one of the first studies that really changed the way we did things when I was at Mayo, and they were doing more ultrasound guided injections. So I want to thank you guys for me talking about non-surgical orthopedic conditions. The journey of 1,000 miles begins with a single step. I'm really glad to be back in my home where I grew up in Bethesda, Maryland, at the hospital that I was born, Sibley Hospital. And I want to thank you guys all for a talk today. Point Performance is located on the corner of Mass Ave and Goldsboro, where I practice, in addition to Sibley. And these are just some of the doctors that are in our practice. And if you want an integrated approach, happy to talk to you about how to manage non-surgical orthopedic conditions. Happy to answer any questions. Hello.
I think they're in the Q&A and the chat.
Okay. So just, Kathy, I should just type my answers, right?
No, you can read the question and then just answer the question as you go.
Okay, so the first one is, who do you recommend for lumbar spinal surgery? Oh man, I don't want to pick favorites here. There's a lot of great surgeons that operate at Sibley Hospital, and I'll reserve that for Kathy to answer. I don't perform spine surgery, so that's something that you should, if that is something that you need. There are a lot of great surgeons that work at Sibley Hospital. The second question, can you do multiple PRP applications for multiple years in the same knee? It's a great question. So we know that one PRP injection will last about a year to a year and a half, but and that's if they have moderate arthritis. Sometimes it can last longer. There's been studies showing that PRP can prevent the need for a knee replacement for 3 to 5 years. But some patients might need another PRP injection after that one. And so we still only know that PRP injection reliably will last at least a year, but it can last longer. Someone asked me to repost my contact info again. I'll do that in a second. The next question, do people combine PRP and stem cell in sequence? That's a great question. There's a lot of people that do offer that. I think that there's not a lot of great evidence yet on does PRP and stem cells really improve. There has been evidence showing that PRP and the gel, that hyaluronic acid, does help out compared to just PRP alone for arthritis. But PRP and stem cells have not been something that's been well studied. The next one is, if I had carpal tunnel release the old-fashioned way in the hand at Sibley 49 years ago, if I have a current problem now, can ultrasound guidance procedure be more difficult now? Yes, it can be more difficult. I think that's a very individual, more challenging situation, but it can be more challenging than what can be done. So if you want to come for a consultation, I'm happy to talk to you about it, but it might be a good conversation for us to have offline. How can heterotrophic ossification of a hip joint replacement be treated? The hip joint is very stiff and has a limited range of motion. There's a lot of bone growth seen on X-ray. So that is a thing that we did not talk about today, but that is extra bone that it can be grown. It's a very challenging thing that can be treated. It can be treated in multiple different ways. It can be treated with NSAID, so ibuprofen. It can be treated with surgery removal. It also can be treated with radiation. That's a topic probably to have a conversation with the surgeon about. So the next one's a really good question. If PRP is so effective, why are insurance companies providing coverage? So it's a really good question. I think I showed you guys today that there's now studies showing cost effectiveness of PRP. I think insurance companies are slow to the game with covering this. And there's not a lot of device companies that are able to work on getting FDA clearance, but that is an important pathway that needs to be done. I do believe that PRP will be covered in the future because the studies, and especially the recent studies that have been done, showing it to be very effective. Is this certain type of ultrasound that is used, not the usual ultrasound practices? Is this a certain type of ultrasound? So this type of ultrasound is used by most practices, but there's special certifications that you should get if you're interested in someone managing your orthopedic injury under ultrasound, using ultrasound. And those were most of, those are most of the questions. Oh, the next one, can calcification disruption be done on the big toe, and is it an outpatient procedure? That is a challenging situation. Calcifications that occur in the big toe joint, they can range from, there's many different causes. I think that's a question that we should talk about offline. It's not something I covered today, but it can help for managing arthritis in certain patients. Will this recording be available for those who joined late or need to hear it again? It's a great question. I think Kathy will be able to answer that. I believe it will. We are recording the lecture, so it should be available to the public very soon. Well, those are all the questions. I really appreciate everyone being on the line today. So if you have any other questions, just feel free to reach out to me. I'm happy to share my contact information one more time, because that was one of the questions that someone had. So this is my information, and this is my email, mgruner@pointperformance.com. Is there anything else, Kathy?
I think we're good if you're good.
I'm good.
All righty.
Thank you so much.